Welcome back to our weekly lectures on future CRNA learning solutions. Thank you for joining us. We appreciate it. Hope you've learned a lot and learn more as we go along. This week, we're going to go over the foundations of paralytics. In this comprehensive section, we embark on an in-depth exploration of paralytics, also referred to as neuromuscular blocking agents, NMBAs, a cornerstone of modern anesthesia and critical care. These powerful medications induce temporary muscle paralysis, a state indispensable for many surgical and medical interventions. Whether facilitating precise endotracheal intubation, providing optimal surgical exposure, reducing oxygen consumption, or enabling controlled ventilation in mechanically ventilated patients. NMBAs are fundamental in achieving safe and effective critical outcomes. Our discussion today will cover not only the pharmacology of these agents, but also their applications, monitoring, and reversal, ensuring a comprehensive understanding of their vital role in patient care. Today, the journey begins with a detailed examination of why paralytics are so integral to medical practice. During surgery, a motionless operative field is often necessary for precision and safety, and paralytics create this ideal environment. Additionally, in synchronization with the ventilator and reduction of respiratory muscle workload, thereby optimizing oxygen delivery to vital organs. In high-stakes scenarios, such as emergency intubations, the rapid onset of certain paralytics is life-saving, ensuring airway security while minimizing complications. By appreciating these clinical necessities, the importance of NMBAs in both elective and emergent care becomes abundantly clear. What paralytics actually do? First time. Paralytics, or neuromuscular block agents like we discussed, NMBAs, represent a remarkable class of drugs that induce temporary and controlled muscle paralysis. Their role in modern medicine, particularly within anesthesia, is profound. The primary function is simple: relax skeletal muscle. What does this allow? But the clinical impact is massive. They allow safe airway control, motionless surgical fields, ventilation control, and reduced oxygen demand. Let's look at some pathophysiology. The neuromuscular junction is where everything starts, the NMJ. This is where a nerve signal becomes a muscle contraction. But in the normal process, a nerve impulse arrives, acetylcholine is released, acetylcholine binds with the nicotinic receptors, the sodium influx then leads to depolarization, and then thereby you have muscle contraction. The mechanism of paralytics. Paralytics disrupt this process in two significant ways. We have depolarizing agents, which is like succinylcholine. It mimics acetylcholine, it binds to the receptor, it causes rapid depolarization, and it does not detach. So you get initial fasciculations, and then you get paralysis. Then we have a second class, which are non-depolarizing agents. These are examples like rocuronium, vecuronium. These are competitive antagonists. So what they do is they block the receptor at the junction, and they prevent acetylcholine from actually binding. So then you get no depolarization, no contraction, but you are still getting your paralysis. You may ask yourself, what are some of the clinical uses of these paralytics? For one, which we use every day pretty much in anesthesia, is for endotracheal intubation. Paralytics relax the vocal cords, they eliminate resistance, and they improve your success rate. Without them, the trauma risk of you intubating increases, and your risk of failed intubation also greatly increases. In surgical optimization, we use it for neurosurgery, cardiac surgery, or vascular procedures. A lot of general surgery where you don't want the muscles to contract and get in the way of the surgeon and just cause them more trouble. It gives them more control of the surgical field and just more relaxed. Physiologically, it allows us to decrease the oxygen consumption. So muscle activity causes increased oxygen demand. Paralytics thereby reduce the metabolic demand and thereby increasing your oxygen delivery. So this is an important adjunct in ARDS, shock, and cardiac compromised patients. And you also use it for ventilation control. In critical care, we use paralytics for knocking out the spontaneous breathing drive, and it allows full ventilator control. So you may ask yourself, when and how do we apply this in clinical application and decision making? So let's go over succinylcholine. This is our fast one. It has an onset of about 30 to 60 seconds, and it lasts about 5 to 10 seconds. 5 to 10 minutes, sorry. 1 to 3 minutes. It lasts about 1 to 3 minutes. You get persistent depolarization, fasciculations, and paralysis, and is metabolized by plasma cholinesterases. Some of the side effects, as every drug has a side effect, complications of succinylcholine is hyperkalemia, malignant hyperthermia, bradycardia, increased intraocular pressure, and increased intragastric pressure. These are all potential complications. On the other side of that, we have our non-depolarizing agents like rocuronium. So a little different. So your onset is 1 to 2 minutes, and your duration is 30 to 60 minutes, depending on which one you use. These are competitive receptor blockades, like we talked about before, and these are metabolized in the liver, and you have biliary excretion. So, how much do we get? Or how do we monitor it? So, we have a device called the Train of 4. 4 stimuli and 4 twitches. So, you interpret that as 4 twitches, you have minimal blockade. You get 2 twitches, you have a moderate blockade. You get 0 twitches, that means they're completely paralyzed and they're deep. So we also have a Train of 4 ratio. If you have a ratio greater than or equal to 0.9, it's clinically safe for extubation. You also have a fade, so it'll twitch and then they'll get less. So these are only present in non-depolarizing agents, and therefore they're absent in succinylcholine. We have some advanced monitoring. Single twitch, it's basic but limited. Tetanic stimulation, you stimulate the muscle and you get it detects how deep your blockade is. And then traditionally we use a double burst stimuli, which is 2, and it's more sensitive than Train of 4. How do we reverse these? Traditionally we've used neostigmine and robenal. How does this work? It increases the acetylcholine, competes with the neuromuscular blocking agent at the joint, and therefore reverses the paralysis. Limitations: it's not very effective in a very deep blockade. You have to overcome the blockade in order for your muscles to contract again. And it can cause also cholinergic side effects. Recently, they've come out with sugammadex, great drug. What it does is actually encapsulates the neuromuscular blocking agent, the drug, and prevents it from actually binding at the joint, at the neuromuscular joint. So it removes it from circulation. So basically it binds to it and takes it out of circulation. Done. Advantages: it's rapid reversal, so you can actually use drugs like rocuronium and whatnot, and it will actually act almost like succinylcholine. You can give higher doses and you can reverse it very quickly. As you talked before, some of these drugs last longer than succinylcholine, so we don't have to worry about the prolonged effects of, say, we can't intubate. The sugammadex will work in a deep blockade, so before we couldn't reverse them, now we can. And it's awesome because you don't have the cholinergic effects. Okay, so traditionally for airway emergencies, we would use succinylcholine or a high dose of rocuronium, because if you need to emergency intubate these patients, you need to have a higher dose of rocuronium for it to work longer. For a longer procedure, rocuronium. You need a rapid reversal, we're going to use sugammadex, like we said. If you have a light blockade, we can use the neostigmine and a little bit of robenal. So critical, some safety concepts. Sometimes in recovery, they'll call us, patients are floppy, they can't breathe, they start desatting. Residual paralysis is a big thing for us. Respiratory failure is a large risk, and then also leading to that, though, if these patients can't protect their airway, it leads to an aspiration risk. Certain drugs we have to be very careful of too for renal failure, liver disease, burn patients, or if these patients have neuromuscular disorders. They don't metabolize the drugs, the junction is different. We have to be very cognizant of that, and sometimes adjust our dosages and also adjust the drugs that we're using. So paralytics are not just muscle relaxers. They are tools that we use for physiological control, tools of safety, and they are tools of precision. So basically what you need to do is understand the neuromuscular junction, the physiology, how the drug works, how to monitor them, and how do we reverse them. You are no longer just memorizing, you are thinking like a CRNA. Thank you very much, and we will see you next week for your next lecture. Stay tuned. Thank you.